Hello, welcome to our educational evening here at UPMC SSC. I'm Fiona Roach, I'm the Business Development Manager here in the Sports Surgery Clinic. Most of you probably do know us, but anyone that doesn't, we're just located off the M50 and the M1 in Santry and about 10 minutes from Dublin Airport. And we are an orthopaedic hospital, as I said, one of the leading private orthopaedic hospitals in the country. So tonight we have three speakers. We have Dr. Philip Hu, one of our pain management specialists, Dr. Leah Rooney, who's one of our new rheumatologists, and Mr. Neil Burke, one of our orthopaedic surgeons. They'll all have their presentation first, and they'll be joining us afterwards for a live Q&A. So if you see the tab there for Ask a Question, just type in your questions there, and we'll answer them once we're joined by the speakers. Also, there's a tab there for a GP liaison if you need to contact her at all. There's also a tab for your CPD points. And just remember, you have to be registered at this to get your CPD points. So please make sure you are registered. Also, all the other events are on our website under recorded events. Now, you do need a password to get into those if you're a professional. And if you contact the GP liaison, she'll be able to give you that as well. There was also another tab there, which is all about UPMC, as we are now one of the UPMC hospitals in Ireland. So I'm going to introduce first Dr. Philip Hu, and Philip is going to talk about Alternative Pain Management 2024 edition, and Philip will join us afterwards. Thank you.
Good morning, everyone. My name is Dr. Philip Hu, and I'm a pain physician at the UPMC Sports Surgery Clinic. Many thanks to the organizers for inviting me to make this presentation today. I would like to speak about alternative pain management. We are in 2024. This is certainly an exciting place, and also from certain aspects, it's a scary place, depending on your point of view. We have rising life expectancy. We have a population that has benefited from the advances in both knowledge and changes in lifestyle. We're eating better, we're sleeping better, we're managing our stress better. And therefore, we have lots of 80 and 90-year-olds who are very fit and healthy. We are also living longer, and the level of activities that we perform are far exceeding those of our parents. We also have the expectation that we will live longer and we can afford to do the things that we want to do. For example, travel, and also access high standards of healthcare. I suppose this brings to us a level of preference, as the expectations of a long and healthy life, a long and healthy active life, are quite high. With the advance of science and with all the resources available to us, we have made lots of investments, for example, in research, to understand the basic pathologies that lead to disease, and also the treatments. So in terms of treatments, we have had lots of advances in terms of drugs. There are drugs that now are custom built to be more efficacious at the receptor level, to be less toxic to us, to be more tolerable. In terms of interventions, there are so many new treatments available. A case in point would be, for example, ablations for atrial fibrillation. They are pretty non-invasive and well tolerated, even by a lot of frail 80 to 90-year-olds. In my own field of spinal cord stimulation, we have a renaissance in the technology, the delivery of the electrical currents that help pain, and also the actual hardware itself. I'm very conscious of the biopsychosocial model in managing chronic pain, and we should never forget that rehabilitation, physiotherapy is a cornerstone, and so is psychology. We must always make sure that the mind remains on side. Very often when I see a new patient, I ask them what do they expect out of today's consultation. These are some of the snippets that they do tell me. We have some suicidal attitudes. No one wants to be on additional regular medication. They may be already on a lot of medication for other comorbidities. They often see surgery as a last resort because of the unpredictability and the potential higher risks involved. Lots of patients, through the success of these TV series on Netflix, such as Dopesick, will be aware of the problems with opioids. They tell me, I don't want to be an addict, no morphine for me. And with the increasing levels of resources and wealth, and also the perception that modern medicine can fix and cure almost anything, the expectations of the patients are, why can't you fix me? Where is my cure? I'd like to present some alternatives to the traditional models of disease management, chronic disease management. You have medications, and we know that lots of patients don't want to be on regular medications. And then we also have surgery on the other side. I would like to talk about three aspects of alternative pain management. The first is Botox. The second, I wish to talk about alternatives to joint surgery, joint replacement surgery. And finally, I would like to talk about the improved and advanced role of spinal cord stimulators. What is Botox? Botox is a neurotoxin that's produced by Clostridium botulinum bacteria. It is quite flexible and useful when injected into muscle tissue. It inhibits muscle spasms by stopping the release of acetylcholine. It also has effects specifically on neuropathic pain. Some of you might have seen this slide before, and I'm going to do a quiz. We're all familiar with some of the commodities, if you like, that are available there. You could hazard a guess, which is the most expensive. Some of you who are gourmands would think perhaps truffles or saffron. Some in the cosmetic business would say creme de la mer or precious metals. Well, Botox is actually right up there with it. Plutonium is the most expensive, costing about $4,000 per gram. And next up is Botox at $1,500 a gram. So it is quite an expensive item, but if it's able to give patients pain relief where nothing else has worked, then some would say that it's worth it. So what are the uses of botulinum toxin? We are familiar with its uses in aesthetic medicine. Specifically for chronic pain management, I see a few roles for it. It is very useful in spasm. We do use it in spasm in smooth muscle in multiple locations, including the bladder, the gut, and also striated muscles, for example, in your neck or in your lower back. It's also very useful for neuropathic pain, patients post-herpetic neuralgia, trigeminal neuralgia, and facial pain. And lastly, it's also very useful in scar pain. I'd like to share with you some of my experience. I've had patients with painful diabetic neuropathy, specifically in the feet, where no other systemic medication or nerve blocks, etc., have worked. And Botox injections, though very painful, some of them can be sedated, have been very useful in neuropathy. Also in trigeminal neuralgia, those of you who have patients with trigeminal neuralgia know that the treatment pathways include stereotactic surgery, trigeminal rhizotomy, which is quite invasive, where a needle is placed in the foramen ovale at the base of the skull. But sometimes you can have mixed results, and patients may have partial responses to the invasive procedures. I also use Botox in the face as a screening test as well. In some patients, they do respond sufficiently to Botox and medication that they do not need a trigeminal rhizotomy. I've also used it very effectively in patients with post-herpetic neuralgia, that's shingles pain. It can affect the intercostal dermatomes or even the lower back and limbs. In patients with cervical spondylosis, I do see a lot of patients who've had road traffic accidents resulting whiplash type injuries, and they again would respond quite well to Botox injections in the paracervical muscles. And of course, lastly, the very good indication of migraine. NICE in the UK, through the PREEM trials, have sanctioned the use of Botox for migraines, and they can be very effective in preventing migraines, severe migraines, to the point that the patients are able to work again. They don't have to lie down when they have bad migraines. So Botox is very useful as an agent. It usually lasts for about 12 weeks. The next aspect of my presentation will deal with joint pain. There are three large joints in the body: the shoulder, the hip, and the knee. And very often, as you grow older, due to the journey that your body has been on, degeneration usually takes place. So a lot of patients, unfortunately, in the 80s and 90s, perhaps are not fit for a haircut. They have anticoagulants and they have certain requirements. For example, they might have stents or TIAs and they are not able to stop these anticoagulants. The whole aspect of recovery and the actual anesthetic sometimes is more severe than the operation. And then to be on painkillers in the longer run without an option for surgery. The stress response often from being in severe chronic pain is also detrimental to their health. So what options are available for these patients? Recently, through the advent of ultrasound imaging and visualization of soft tissue, including nerves and blood vessels, we can now more accurately identify the areas where denervations can take place. Any joint will have sensory and motor innervation. If there is an opportunity to figure out where the sensory branch comes off, then there is a target possible with denervation. Very often, we do combine ultrasound and fluoroscopy with X-rays, and that can prove to be very effective in denervations. Taking the shoulder first, shoulder pain can be very debilitating for patients. They commonly present alongside with stiffness and weakness. Everyday tasks such as reaching overhead, driving a car, checking the blind spot, brushing your hair, and putting on clothes might be very difficult. The shoulder joint is a complex joint and there are many reasons for their pain. They could include adhesive capsulitis, osteoarthritis, and also trauma or avascular necrosis. The muscles and tendons can also get inflamed and they can also get torn. And not every single tear requires an operative repair. Very often, patients are in such significant pain that they cannot rehab at all. And from a tear, it leads to adhesive capsulitis and worsening function. I work with a very good team of shoulder surgeons, and usually there is a pathway where imaging is performed, the problem is diagnosed, injections may take place, but then the injections may have mixed results. Some patients are candidates for replacement surgery and others may not be. So that's the role where I come in, where I can perform pulse radiofrequency or radiofrequency of these sensory nerves. So as I've mentioned, with the advent of ultrasound and dynamic imaging, we're able to identify the articular branches and the sensory branches of the suprascapular nerve and the axillary nerve on the back of the shoulder, and the lateral pectoral nerve and subscapular nerve in the front. The diagram on your left shows the shoulder with the patient facing you. So on the lateral aspect, you have the axillary nerve, but in the front of the chest, you have the lateral pectoral nerve and the subscapular nerve, which innervates the anterior part of the shoulder joint. If you look on the right-hand side of the slide, you will see the spine of the scapula. So we're looking at the patient from behind. And again, the posterior aspect of the glenohumeral joint is innervated by the suprascapular nerve and a branch from the axillary nerve. The axillary nerve looks after the deltoid muscle. In some patients, there's very little movement. So if they do not use their deltoid, you could sacrifice that branch of the nerve. even with the motor side of things. This is an ultrasound image showing the radiofrequency ablation of the suprascapular nerve. It's quite an easy procedure to do, and it's well tolerated. You see the trapezius muscle and the suprascapular muscle, and then down below you see the suprascapular artery underneath the suprascapular ligament. And in the fossa is the nerve. You can stimulate the nerve along the way, and you have motor branches, and as you go closer to the shoulder joint, the motor stimulation will cease, and that's when you know you have the articular branch, and then you can do the denervation. Studies for shoulder joint denervation have shown that you can get 6 to 9 months of good relief. Nothing is permanent, unfortunately, and no other alternatives. This is a good option. Next, we come to the hip joint. The hip joint has many pain generators, including the capsule, the ligament, the bursa, the muscles, and the tendons. Most patients at some stage will have their hip replaced, and usually that lasts for 15 to 20 years, depending on your activity. Revision surgery is fraught with dangers, and often this radiofrequency ablation can be an option for the patient. Primarily, there are 3 nerves that look after the innervation of the hip joint. You have the articular branch of the femoral nerve, the articular branch of the obturator nerve, and the articular branch from the sciatic nerve. And these can be accessed either in the front or the back of the hip joint, depending on the patient's main pain. This can be aided with ultrasound and combined with fluoroscopy. So the femoral nerve looks after the greater trochanteric area, the obturator nerve looks after the groin and the thigh, and the sciatic nerve looks after medial gluteal pain. We come now to the knee. Knee surgery, knee replacement surgery is often trickier to recover from than hip surgery. And there is also the potential for complex regional pain syndrome development. We used to think that there were only 3 important nerves in the knee, the superior, lateral, and medial genicular nerves, and the inferior medial genicular nerve at the edge of the tibia. We now know that there are 7 branches of the genicular nerves that are important. Very often with patella chondrosis, you do require blockade of the suprapatellar branch as well, which is often missed. These techniques have now been refined. We have new targets in terms of the adductor canal, and that has boosted the response rates from genicular nerve ablation for nerve pain. We are using larger electrodes and longer lesions with combined imaging techniques. This has improved the response, as I said, and the efficacy. In terms of sensory denervation of major joints, how do you select the patients? You have elderly patients with arthritis with multiple comorbidities. You can also have a very young patient. We've had a few in their 30s and 40s who have had sports injuries earlier in their careers and now are struggling in their 40s, but they're still a bit too young for a knee replacement. So what do you do with them? Most patients, as I said, do not want to be on long-term medications, including opioids or anti-inflammatories with their concurrent risks. Some patients are reluctant to undergo surgery, full stop. And it's useful because as an alternative, these patients can have these procedures even after surgery. I wish now to focus a little bit on the spine. I talked about the advancing roles of spinal cord stimulators. We have a different nomenclature in terms of spinal pain now. So there's persistent spinal pain syndrome, either 1 or 2, depending on whether you've had surgery or not. It replaces the previous failed back surgery syndrome, if you've heard of it. Some patients are what we call primary backs, where they're not a surgical candidate based on the imaging. However, they have very bad either axial, so pain in the back, or radicular pain down the leg. They have done as much rehab as possible. They are religious with their rehab, but yet they are not making any progress. They've had a series of injections. Some injections work well, some injections don't work well, or the duration of the injections is too short. And often medications are put in at the same time to help the patient to continue to move. So where do we go from here? Recent studies have argued that perhaps these patients should not be told just live with it, that there are options to improve their function, reduce medication, improve the quality of life, and perhaps maintain employment or return to employment. Just a word about spinal cord stimulators. Some of you may be familiar with what it does. In the most basic sense, it is a bit like a pacemaker in your spine. Electrodes are placed in the in the epidural space next to the spinal cord, usually in the thoracic area, and it targets different pains. Usually, it works well for radicular pain, so pain in the limbs or the legs, and also it now is very helpful for pain in the back itself. There was a recent controversy where there was a trial that was done specifically to discredit it, but there were so many flaws in the actual trial. If you do hear about it, it was an Australian trial that it hasn't gathered much momentum. There is also a question about the cost to the patient. In terms of the way I trial stimulators with my patients, there's a concept of a test drive. So it's a bit like going to a garage. You fancy you like an electric, you try out a BYD, which is a Chinese manufacturer, which is bigger than Tesla now. And but you don't like the feel of the drive. You might be more traditional. You like the sound of an engine. You like the way the car feels, and it's more passion than function. Then you might not like the car at the end, and you return the keys, and it should cost you nothing. So similarly, for my patients, if I do trial them with spinal cord stimulator, it would be very similar to having a test drive. I will place the needle in position and advance the electrode, and the electrode is stitched to the skin itself. So therefore, there is no scar and no wound. If the patient responds to it, we can implant it. If the patient doesn't respond to it, I will remove it, and the patient is no worse. Just a few words about advances in stimulation. So we have the concept of closed loop stimulation. In the past, we used to send electrical signals into the spinal cord, and we didn't know what the spinal cord response was. With closed loop stimulation, you have a better response rate at 24 months, about 80%. And also in the trial phase, you can actually check whether the spinal cord is activated. There are some patients for which nothing will work. And if the spinal cord isn't responding due to nerve injury or spasticity changes, then it will be a waste of time. This is an additional benefit in terms of finding out whether the patients respond in terms of clinical aspect, but also you have a technical recording. So closed-loop simulation means that you keep, in the same way that you have drug dosing and plasma concentrations, you have to make sure that if you like, the electrical dosing remains in the therapeutic range. But that can change with posture. If you look on the left-hand side, with coughing, with bleeding, etc. And this helps to refine that. Next, we have FAST, which is fast-acting subthreshold therapy. And again, this is a different type of electrical current, and it uses surround inhibition. Basically, it blocks off the area of the spinal cord to where the pain is coming from by activating other nerves that will inhibit a wide dynamic range neuron. This is a bit of physiology, but I'm just saying that there are different ways that it can help. And lastly, there's dendritic stimulation, where you recruit more nerves than you would normally. So this is the gate theory of pain, where you only have one inhibitor with dendrites. Dendrites are the small little branches of nerves, pain fibers, and by activating more of them with using more electricity, this is the new data that's come out. You can have longer duration of efficacy of pain relief without any tolerance. So I hope I presented 3 alternatives on how we can manage pain a bit better in our aging population who wish to be active for longer. It's important to try to get a specific diagnosis. Often interventions are operator dependent. We have more options for electrical delivery of spinal cord stimulation. And also this can be used in terms of rescue. And for any of you who are worried that these patients who get implanted cannot have MRIs, they are now all MRI conditional, and we can get MRIs done in them. I'd like to leave you with a few thoughts. So on the left-hand side, you have the New Zealand Paralympic team training, and they are using a tandem cycle. So pain management is, I believe, should be used in tandem, because in tandem, you can go further. The lady in the back seat is blind, but she can participate in sport and contribute and perhaps achieve things that she couldn't on her own. And that's the same way I would work well within a team. We don't want to end up like this guy on the right-hand side. He's exhausted because all the therapies have failed. He's now exhausted to the point that he's blind. He can't read the no parking sign, and his bicycle is deemed useless, so he's not getting anywhere. So I hope that alternative pain management can help and complement other treatments that keep our patients healthy and active for longer. With that, I conclude my presentation and I'll be happy to take questions. Thank you very much.
Philip, thanks very much for a really interesting talk. Right, we're going to start now. First question, will Botox work for shingles? Now, I think you covered that a bit, but maybe elaborate a little bit more.
So Botox is a toxin produced by Clostridium botulinum. It is active at nerve terminals, and we use it in pain management for a number of indications. One of them is the treatment of severe muscular spasm, usually either in the neck or the lower back. It, however, is very useful, and it has a nice endorsement for the treatment of chronic migraines using the PREEM protocol. Also, it's very useful for peripheral neuropathic pain, and shingles would come into that category. I recently had a lady with very severe occipital neuralgia shingles, and after the acute phase with antivirals, etc., the use of Botox, we were able to dampen down her pain to the point that she could sleep and she could move her head again. Botox itself, in terms of the injections, it's a subcutaneous injection. It doesn't go into the muscles when you're using it for neuropathic pain. It is also very helpful for facial pain. It has been useful in trigeminal neuralgia when trigeminal rhizotomies have incomplete results. So there are some residual areas where rather than going to do an invasive procedure, Botox is very well tolerated. We also use it in shingles, for example, in the thoracic area, and also for diabetic peripheral neuropathy, and also for post-surgical scar pain. So the short answer is yes, it does work for shingles.
So, and how long does it last?
The Botox chemical itself, the duration of action is between 8 to 12 weeks, and usually the body will excrete the chemical during that time. In certain situations, especially such as shingles, the pain initially can be quite severe, and with first treatment of Botox, if it does come back when the Botox is eliminated, the pain is not as severe. And sometimes with other alternative managements, you can keep it at bay. Sometimes it requires 2 or 3 sets of injections before the pain ultimately settles.
Great. And what about migraines then? Would that be?
Yes, we have a lot of experience with using Botox for migraine. So the PREEM trials were done in the early teens, 2011, 2012, with the neurologist, and there are set positions where you inject the Botox. There are 35 different locations and use 155 units. These injections are repeated every 12 to 16 weeks. For chronic migraineurs, you have to have more than 15 bad migraine days in a month. And usually with the combination of biologics and Botox injections, the majority of migraines can be controlled to a level where the patients can have a reasonable quality of life.
Okay, thank you. What do I do if a patient is not suitable for surgery? They're in a lot of pain, but they don't want to be on strong painkillers long term.
That's a great question. We are seeing a much older population. They often have medical comorbidities. Their organ functions may not have the resilience to withstand an anesthetic. They may not have the rehabilitative capabilities to rehab themselves after surgery for good outcomes. In this situation, if they don't want to be on strong medications, then interventions should be tried. Most of the time, the diagnosis has to be correct in order for the interventions to work. So usually if patients are sent to me through another specialist, the diagnosis is clear with clear imaging to confirm it, then injections do help. And in some situations when local anesthetic and steroid injections don't last beyond 3 months, then there are denervation procedures, which I spoke about in my talk, especially for the shoulder, the hip, and the knee joints. And these have good potential to give you 50% relief for 6 to 9, maybe even 12 months.
Okay, thank you. Someone just as asked here, just going to move this one over while we're talking about the Botox first of all. Sorry, bring it up there. How often can Botox be used for muscle spasm? Are there side effects?
So Botox is actually a very well tolerated chemical. The actual genuine anaphylactic reaction to Botox is very, very rare. Most times there can be small instances of redness around the areas where the injections take place. When you inject for muscle spasm, it requires deeper injection because you have to get into the belly of the muscle. Whereas if you're injecting for neuropathic pain, it's more superficial. So in some patients, there can be a certain amount of flare-up. It doesn't make sense to anesthetize the skin with local anesthetic injections followed by the Botox. So what we do is we make sure that we perform the Botox very quickly. We have the adequate length of the needle, and we minimize the size of the needle for patient tolerability. Botox can be done every 12 weeks if required, but again, in both cases, both neuropathic pain and with spasm, in clinical practice, we don't repeat it that often. We don't need to repeat it that often. Usually, for example, if there's back spasm, the Botox breaks the spasm. If the spasm does recur, a combination of small doses of medication as and when required, lifestyle changes, rehabilitation, Pilates, swimming, all the above will help the patient to have a good outcome for longer.
Okay, thank you. Ask here, any specific guidelines regarding orthopedic post-operative pain management?
I think the Sports Surgery Clinic runs a very good post-operative pain management protocol where multimodal analgesia is used together with early rehab. And from that perspective, pain management is pretty successful. There are, of course, the chronic pain patients who can develop joint arthritis and require surgery. In those situations, we have our specialist staff on the wards, making sure that these patients have adequate, appropriate analgesia. Should they need additional analgesia, I'm on hand to provide a consultation and to guide their management. We don't usually use local anesthetic catheters or local anesthetic infusions because that can often lead to complications, local anesthetic toxicity, infection, motor blockade leading to slower rehabilitation.
Okay, there's another question here. So what are the contraindications for using Botox? Now, it's not really your field for overactive or leaky bladder, 91-year-old, history of prostate cancer, 17 years ago, takes warfarin. But I said I'd ask you, you said, yeah.
Yes, thanks, Fiona. This is not my field of expertise, but there are very good urologists within the UPMC network. The closest for us would be in Klein. There are a lot of more non-invasive procedures, treatments that are developed now for specifically this patient population, elderly on anticoagulants who need a lot of TLC.
Yeah, So I suppose the warfarin thing would be relevant to any patient, wouldn't they, if you put them on Botox as well?
In general, we have gained more confidence and experience in terms of injections while on anticoagulation. So there are guidelines both by the Regional Anesthesia Association through anesthesia and also the Pain Management Specialist Associations in terms of the not just anticoagulants, we have antiplatelet agents, etc., and when we should stop them and for how long and when to resume. We always take these decisions on a individualized basis, taking into account the patient's pathology. We also consult the physicians who have started these medications, for example, cardiologists, stroke physicians, neurologists, etc., and we come to a consensus with the patient on how to deal with these. And in general, unless you're going to the spinal canal, it is not an absolute requirement to stop these medications. And for injections into joints, it will be similar. We are meticulous in terms of our technique, in terms of trying to achieve first pass positioning of the needles. And of course, we tell the patients to be diligent about, and also to warn them potentially that the bruising might be worse and to look for any signs that might indicate a problem, such as pressure swelling from hematoma.
One more question here. Would sensory denervation be an option for a young patient, that's 35, requiring a total hip replacement due to dysplastic hip that was not identified as a child? Patient is highly active runner, but limited due to the high pain in the hip and wants to delay a total hip replacement on advice of hip surgeon. Is there a risk of motor loss?
That's a great question. Recently, what has changed our view on denervations is that with ultrasound, we're able to isolate, identify through sonar anatomy the articular branches that are sensory more than motor. We know the branches that go to the big muscles around the hips, and we try to leave them out. In this sort of situation, I would tread quite carefully because she's 35 and very active. So what we would do is we would firstly test the hypothesis that we can turn off the pain, injecting the articular and sensory branches initially. We see how long they last in terms of the injections, and then we can escalate up using either pulse radiofrequency, and if it's a case that the pain relief was very profound but short-lived, then a denervation is an option.
Okay, thank you, Philip. Thanks so much for joining us tonight. So our next speaker is Leah Rooney, and Leah is a new rheumatologist with us here at Sports Surgery Clinic, and she'll join us for a Q&A afterwards. Thank you.
Hello, my name is Leah Rooney. I'm a rheumatologist working in the Sports Surgery Clinic, and today I'm going to present some rheumatology cases. So my first case is a 35-year-old lady. She presents with pain and stiffness in both hands. This is ongoing for about 2 months, and she has associated fatigue. You can see in this picture here that there's inflammation in her MCP and her PIP joints in both hands. So here we have joint synovitis that's presenting in a symmetrical fashion in multiple joints in her hands, and this is really in keeping with a rheumatoid arthritis pattern. So looking at the blood tests, you can see the inflammatory markers are slightly elevated, rheumatoid factor is strongly positive at 100, and anti-CCP greater than 240. So this case is in keeping with a seropositive rheumatoid arthritis. And what seropositive means is that rheumatoid factor or anti-CCP or both are positive. And about 70% of patients with rheumatoid arthritis will be seropositive. Those who are diagnosed with seronegative rheumatoid arthritis don't have these antibodies, but they're presenting with the typical rheumatoid arthritis pattern. So rheumatoid arthritis, it's important to treat this early. With earlier intervention, you're going to achieve disease remission, more likely to achieve that, and you're also going to have less joint damage. When you detect synovitis, as in this case, it's good to give an initial course of prednisolone with a starting dose of about 15 milligrams and tapering by 5 milligrams every 2 weeks. So we want to initiate disease-modifying therapy, and our usual first go-to medication is methotrexate. It's important also to monitor the disease activity and to treat to target. Failing a disease-modifying therapy, we're going to consider additional biologic therapies or JAK inhibitors. So looking at the X-rays here, so in the first X-ray, which is early ORA, you can see the kind of first radiographic changes that you see with ORA, which is periarticular osteopenia. You can see that at these MCP joints. And here you've got more severe rheumatoid arthritis, and you see joint space narrowing, and you see erosions here at the joints. Here you can see a very severe case, and there's subluxation at the MCP joints, and that's giving you the ulnar deviation of the fingers in both hands. And you can also see here on the right a boutonniere's deformity with flexion at the PIP and hyperextension at the DIP. So our DAS28 CRP is a tool that we use to monitor disease activity. And the score that you get from this will classify it as either disease remission, low disease activity, or high disease activity. So this uses 28 joints, and you can see the joints outlined in the picture here. And you look at your tender joint count, swollen joint count. Also ask patients to give a score of their pain level, and this is using this visual analog scale. And then also it uses the CRP. So this can be helpful in treating to target. So we're trying to up-titrate our DMARD therapies to achieve either low disease activity or remission. So as I mentioned before, our first go-to medication for most patients is methotrexate. Other conventional DMARDs include sulfasalazine and leflunomide, and hydroxychloroquine can be used as add-on therapy. You can see on the second column here, these are our biological DMARDs that are available for rheumatoid arthritis. Our first group here being our anti-TNF agents. We also have anti-interleukin-6 agent called tocilizumab, anti-T-cell agent abatacept, and anti-B-cell rituximab. Our newest group of medications then is our JAK inhibitors, which are taken in tablet form. So just a quick mention of rheumatoid arthritis in pregnancy, as this is a disease that frequently comes on during childbearing years, and it's much more common in women. So obviously managing this during pregnancy is so important. It's important to plan pregnancy in advance, because you want to try and make sure that the disease is as controlled as possible to reduce the risk of any pregnancy complications. But most rheumatoid arthritis patients will experience reduced disease activity during pregnancy, although many of these will experience postpartum flares. Medication management is essential. So sulfasalazine and hydroxychloroquine are safe to continue throughout pregnancy and breastfeeding. Methotrexate and leflunomide are teratogenic, and both are absolutely contraindicated and need to be discontinued at least 3 months before falling pregnant. TNF inhibitors are not contraindicated in pregnancy. Certolizumab is one of our TNF inhibitors, and that doesn't cross the placenta and can be continued throughout pregnancy. And so this is often a drug that we would choose to prescribe for patients with rheumatoid arthritis that are planning pregnancy. Other biological DMARDs, so our tocilizumab, abatacept, and rituximab, can be continued as someone is trying to conceive, but are usually discontinued when pregnant. JAK inhibitors also are contraindicated and should be discontinued 3 months before conception. I've just included at the bottom here a useful resource, which is guidelines in terms of management of rheumatic diseases and medications during pregnancy. So my second case is a 54-year-old man. He presents with knee pain and swelling with associated erythema ongoing for a few days. He describes feeling unwell and symptoms of fever. He has a background history of diabetes, blood tests show a very high CRP and his urate is 400. So the important thing in this case is our differential here is of septic arthritis versus a crystal arthritis, and this joint would need to be aspirated to diagnose this. So this patient has aspiration of the joint, which shows a negative brown stain and is culture negative. It does show these needle-shaped crystals in keeping with gout. So the diagnosis here then is made of acute gout. So things to ask with acute gout. Associated comorbidities are your metabolic syndrome, diabetes, hyperlipidemia, hypertension, and CKD. There are drugs which can elevate uric acid levels, and particularly your thiazide and loop diuretics. Lifestyle, the main things being alcohol excess and high purine diet. Is there a history of previous episodes, and is there a history of renal calculi? Just of note, the serum urate can be low or normal during an acute attack in about 20% of cases, and if this is the case, it's important to recheck it about 2 weeks later. So treatment of acute gout. So we have 3 first-line treatment options, which are our NSAIDs, colchicine, or prednisolone. Colchicine can be used in combination with either of the other 2, and particularly good for polyarticular flares. Now, polyarticular flares usually occur with long-standing disease, with poorly controlled disease, whereas monoarthritis is the more common presentation, and it typically affects the first MTP joint, ankle, or knee. The usual treatment is for 1 week. But when to start urate lowering therapy? So the guidelines would suggest when there's 2 or more flares of acute gout in 1 year, when there's evidence of tophi, chronic kidney disease, or renal calculi. So the important thing with urate lowering therapy is that we treat to target. So we want to try and get the serum urate less than 360. Our xanthine oxidase inhibitors are a first-line treatment for urate lowering, and these are allopurinol or febuxostat, and allopurinol really is the first line out of these 2. The starting dose of allopurinol is 100 milligrams once daily, or 50 milligrams in cases of CKD 3 or worse, and this dose is up-titrated until your target is reached. The doses of allopurinol can go as high as 800 or 900 milligrams a day. Our starting dose of febuxostat is 80 milligrams and can be up-titrated to 120 milligrams, but it's not our first-line option, and it's definitely not with those with cardiovascular disease. Uric acid should be measured every 4 weeks until the target serum urate has been reached. Once the target is met, then you can measure it every 6 months. Gout prophylaxis is very important when initiating urate lowering therapy. So when you reduce your serum urate, you get remodeling of the uric acid crystals in the joint, which frequently leads to gout flares. So the gout prophylaxis we would usually use would be colchicine, but if this is someone's intolerant to this, low-dose NSAIDs is an option, or if there is a contraindication to this, a low-dose prednisolone. Gout prophylaxis should be continued until serum urate, our target serum urate, is met, which is less than 360, and that there's no ongoing disease activity. So this is usually continued for 3 to 6 months. So my third case is a 26-year-old man who presents with lower back pain, which started 6 months earlier. He describes the pain awakening him from the night during the night. He feels worst in the morning times and has some early morning stiffness, which lasts hours. He describes improvement in the pain when exercising. So here we have a description of inflammatory back pain, and this may be in keeping with the diagnosis of axial spondyloarthropathy. So other relevant questions to ask are, what is his response to NSAIDs? Does he have any peripheral joint symptoms? Is there a history of psoriasis? Is there a history of uveitis or any symptoms which are suggestive of inflammatory bowel disease? If it's not contraindicated, this person should be started on a regular anti-inflammatory. There are relevant investigations here. So a CRP, HLA-B27, routine blood tests, rheumatoid factor, anti-CCP and ANA aren't relevant investigations in this case. An X-ray of the lumbar spine and sacroiliac joints is usually normal in these cases. So this patient has only been symptomatic for about 6 months, which really isn't a long enough disease duration to give you X-ray changes. So we'd have to proceed on with an MRI to try and give us a diagnosis. The most important area that you want to image is your sacroiliac joint. And when asking for that MRI, you want stir sequencing. So this MRI imaging is the best for looking for bone marrow edema and inflammation and diagnosing sacroiliitis. So you can see an MRI here, which shows bilateral sacroiliitis. Blood test results show CRP is 16, HLA-B27 is positive, and the rest of the routine blood tests are normal. So this gives this patient a diagnosis of an axial spondyloarthropathy. So the first treatment for this patient would be regular NSAIDs, which are disease-modifying therapies in this condition. Conventional DMARDs such as methotrexate and sulfasalazine don't work for axial disease. So we have to then use biological DMARDs when the patient is still symptomatic despite NSAID treatment. So the biological DMARDs that we can use for this condition are TNF inhibitors and anti-IL-17A inhibitors. Also, newly available are the JAK inhibitors as well. The BASDAI is a useful tool to monitor disease activity and once again helps us treat to target. So my next case is a 41-year-old man. So this man presents to the Rheumatology Clinic with a 6-month history of hand pain and stiffness. On further questioning, he describes new Raynaud's phenomenon, and this started 1 year earlier when he was 40. He also describes worsening of exercise tolerance and shortness of breath on climbing hills. Now, our first clue in this case is that new Raynaud's phenomenon. So primary Raynaud's should start in the teenage years or in the early 20s, and it's abnormal for Raynaud's to start at this age. When it does start at this age, it's suggestive of a connective tissue disease. So looking at some pictures of this man's hands, so you can see swelling in the MCP and PIP joints. There's also erythematous rash over the MCP joints in keeping with Gottron's papules. There's erythema around the nail beds, which we call periungual erythema. And then looking at the skin here in the hands, you see cracking and fissuring of the skin in keeping with the mechanic's hands. And then a close-up here of the nail bed shows abnormal dilated capillaries. So blood tests here, so the most important blood tests, your ANA, and then going on to do your ENA panel. So he's ANA positive, and his ENA panel shows anti-Jo is positive. Rheumatoid factor, anti-CCP are negative, and his creatinine kinase is elevated at 300. So these findings are in keeping with an anti-synthetase syndrome. He goes on to have a high-resolution CT thorax, which identifies interstitial lung disease and is treated with mycophenolate mofetil, which is an effective treatment for his connective tissue disease and with associated ILD. So anti-synthetase syndrome typically presents with Raynaud's, with fever, arthritis of the hands, and evidence of mechanic's hands. It can present with or without myositis, and the myositis involves the proximal muscle muscles, and so proximal muscle weakness. Even without those symptoms or clinical findings, the patients typically will have an elevated CK. It's associated with interstitial lung disease, and so always looking for that is important. New Raynaud's over the age of 30 is abnormal, and it's suggestive of an evolving connective tissue disease. You can see the image over here shows all of the antibodies that are associated with anti-synthetase syndrome. Anti-show is the most common, and it's part of the ENA panel. Other antibodies, all these other antibodies are detected on a myositis panel. So our connective tissue diseases are a group of diseases which encompass SLE, systemic sclerosis, idiopathic inflammatory myositis, mixed connective tissue disease, and Sjogren's syndrome. Sometimes a patient will be diagnosed as an undifferentiated connective tissue disease, and these are patients who have one or two features of connective tissue disease, but that don't fulfill the above diagnoses. And you can also have overlap between these connective tissue diseases. All of these can have can be associated with interstitial lung disease, so it's important to investigate for that. An ANA is positive with all of these conditions, and an ENA panel is then usually performed with a positive ANA, and I've just given you the main antibodies on the ENA panel and their association. So anti-Rose associated with Sjogren's and SLE, anti-La, once again, Sjogren's and SLE, anti-Smith with SLE, anti-RNP, mixed connective tissue disease, anti-Jo1 with inflammatory myositis, or specifically anti-synthetase syndrome, anti-LCL70 with a diffuse cutaneous systemic sclerosis, and anti-centromere with limited cutaneous systemic sclerosis. So my next case is an 80-year-old man. He presents to his GP with bilateral shoulder and hip pain and stiffness. His symptoms are ongoing for 2 weeks. Blood tests show high inflammatory markers, his CRP 100, ESR 85, hemoglobin is slightly low at 10.5, and white cell count normal. So this clinical presentation is in keeping with polymyalgia rheumatica, and he started on prednisolone 20 milligrams. He attends the clinic 2 weeks later after starting his prednisolone and describes no improvement in his symptoms. His pain and stiffness are ongoing with associated fatigue, and he's no new symptoms. So that's kind of a concern at this stage, because with polymyalgia rheumatica, we expect the patient to have resolution of symptoms within 24 to 48 hours of starting steroids. So repeat bloods show the inflammatory markers remain very elevated. Clinical examination isn't hugely informative. There's pain and reduced range of movement of the shoulders and neck, but there's no evidence of joint synovitis. So at this point, we're concerned that this could be a GCA, which is presenting with PMR with subclinical vasculitis. On further questioning, this man has no cranial features, no headache, jaw claudication, scalp tenderness, hasn't had any visual loss. He's sent for a CT aortogram, which confirms the presence of large vessel GCA with aortitis and vasculitis of his axillary and subclavian vessels. He's then treated as a large vessel GCA with prednisolone 60 milligrams commenced, and his symptoms resolve within 24 hours. So large vessel GCA is a subtype of GCA, which involves the aorta and the first order branches of the aorta. Patients with this type of GCA will often not have cranial disease, so often won't have your typical features of GCA, such as headache. They can frequently present with polymyalgia rheumatica with a constitutional upset, or with a fever of unknown origin. The diagnosis is made via imaging, so that can be a CTA, an MRA, or a PET-CT, And I've got a picture here of a PET CT showing aortitis and inflammation of the subclavian and axillary arteries as well. For GCA, there's no associated autoantibodies, so our negative ANCA and ANA isn't very informative. Treatment is commenced with high-dose prednisolone. So for this large vessel GCA, we would typically give a dose of 60 milligrams. If there's a case of uncomplicated cranial GCA, a dose of 40 milligrams is usually sufficient. But with large vessel disease or with disease with ischemic manifestations and vision loss, a starting dose of 60 milligrams is recommended. Frequently, these patients will be prescribed other disease-modifying agents, particularly when the dose of prednisolone is brought down further. And these will be either methotrexate or tocilizumab, which is an IL-6 inhibitor, which is licensed for GCA. That is the end of my cases, and thank you very much for listening, and I'm happy to take any questions.
Hi, Leah. Welcome to your first talk, and thanks very much for joining us tonight. So look, we'll start with the questions. The first one is, should joint pain always have, patients who come in with joint pain, should they always have blood tests for autoantibodies?
So no, not always. It really depends on the clinical presentation. So somebody who's coming with back pain, you know, that person doesn't need rheumatoid factor, anti-CCP, ANA antibodies. You know, if there's a sense that that might be an inflammatory back pain, then a HLA-B27, maybe the relevant blood test and your inflammatory markers there. If it's presenting with kind of polyarticular, small joint involvement, then you're kind of thinking this looks like a potential rheumatoid, and thinking about doing your rheumatoid factor and anti-CCP antibodies. And a monoarticular, so one kind of joint involved, you know, that's not something that really you'd be thinking about rheumatoid arthritis. So I suppose you have to be kind of careful when you're doing these blood tests, because then of course you can get false positives back. And then of course, when you get a positive rheumatoid factor back or a positive ANA, then of course you have to think, what am I doing with this next? So I suppose it's just thinking about the clinical presentation before you're ordering the tests. And I think ANA is one that is ordered on a lot of people who really don't have the typical connective tissue disease features. So it's just thinking about the clinical presentation before ordering them.
Okay, thank you. Is there any specific monitoring if someone is on biologics?
So, well, the biologics, we would do 6 monthly blood test monitoring on that, and that's really just looking at, you know, kidney function, liver function, blood counts. We'll often look at inflammatory markers as well, but that's more kind of monitoring disease. When it comes to our conventional DMARDs, so that's kind of our methotrexate, sulfasalazine, leflunomide, we do more frequent blood test monitoring on that. So when you first initiate the medication, it's quite frequent blood tests, and then it goes down to every 12 weeks, but it's really 12 weekly blood test monitoring, and we're mainly monitoring liver and blood counts on the conventional DMARDs. And then when it comes to like these patients, obviously on biologics, conventional DMARDs, we're always going to be recommending, you know, making sure they're vaccinated as well is important.
Okay, thank you. If I'm worried that a patient has axial spondylosis, what blood test can the GP do to confirm diagnosis?
Well, there's no blood test that will confirm the diagnosis there, but obviously inflammatory markers. So I suppose in that case, you're looking at somebody who's coming in with what sounds like inflammatory back pain, and that was one of the cases that I touched on in the talk there. So if they're coming in with inflammatory back pain, a HLA-B27 is certainly a useful blood test, and if it's coming back positive, it's giving you more weight towards that diagnosis, but it's still not a diagnostic test as such. CRP, so your inflammatory markers, are useful in that situation once again, not diagnostic. And really when it comes to the axial spondyloarthritis, You can, of course, get a diagnosis sometimes on X-ray imaging, but in the early stages of the disease, it's usually MRI that we need to make the actual diagnosis.
Okay, Leah, thank you very much for joining us tonight. And now we have our next speaker, which is Mr. Neil Burke. Neil's one of our knee and hip surgeons here. And Neil's talking about adult knee pain, a diagnostic algorithm. And Neil's going to join us afterwards for a live Q&A. Thank you.
So I'm going to do a talk today on the adult knee, and it's a diagnostic algorithm for this here. And this is one that I would use in my everyday practice. So whenever I'm assessing patients that come in with the knee issues. So the main reason why would I use this approach? Well, it sort of really helps me hone down on the clinical examination and sort of decipher out what I really think what the issue is. And then based on this here, I can order the most, and it is very important to say this, the most appropriate investigations that are needed. And then there's the other cases, and this is very important for yourselves and probably in general practice, is that when things aren't fitting together, do you know what I mean? Like, I think we should all be looking outside the box and sort of be aware of these things, because these are the ones that can catch us out, such as the red flag ones, like the tumors and things that got there. And like, they aren't that common, but you will see them. They do come through. So where to start? And again, it's all in the clinical history. Like, it's in the questions that you ask them. Like, and that's why you have to be you have to have a good approach to this, take a good pain history, exactly what the issue was, you know, the timing of when this started, you know, when the symptoms first occurred. And then based on this here, you'll sort of have an idea of what the issue is, whether it is a meniscal injury or whether it's you know, like somebody with osteoarthritis in their knee. And then what you're doing is just using your clinical examination just to confirm what you think it is. And again, you can order the most appropriate investigations for the patient and then use your resources, you know, wisely. So whenever the knee is a very superficial structure, so we have to keep in mind the anatomy of what's going on. Like, if it's at the front of the knee, there's the patella, and you have your patellar tendon and your quad tendon. If it's on the medial side, you're looking at the sort of like the articular cartilage over the medial femoral condyle or the medial tibial plateau. And then there's your soft tissue things like the meniscus and then the collateral ligaments. More centrally, you'd have your cruciate ligaments, your anterior and your posterior. And then laterally, again, you have your like the articular cartilage covering the bone, the lateral meniscus, and then the lateral collateral ligaments. So in this all, it's where to start. So very basically, we start off, was this a traumatic event or was it a non-traumatic event? So if it's a traumatic event, like you're thinking, first of all, it could either be a bony injury or a soft tissue injury, okay? So the most obvious one is like if it's a fracture, there's a bony deformity and they're in severe pain and they're unable to weight bear. And this is when you refer them to, the patient needs to immediately go to an accident and emergency department and sort of be assessed there. And there they can have their x-rays and their investigations performed immediately and have have assessed. Below is a very common one, like a young guy was playing football and he sustained like in a tackle, he had a dislocated patella, and so like they were unable to reduce it, so he went to the NE department and they're able to give him some sedation and reduce it more appropriately then. So whenever it's a traumatic injury, again, it's back to the anatomy. So on the medial side, you're looking at your menisci and your medial collateral ligaments, as well as the cartilage and the articular cartilage that's covering the ends of both the medial femoral condyle and the medial tibial plateau. And again, on the lateral side, you're looking at the lateral meniscus, the lateral collateral, more centrally, your cruciate ligaments. So it's just important to keep these, just trying to re-emphasize the importance of this. So if it's a traumatic event, as I said before, it's all in the history. If it's a medial meniscal tear, the patient will they may not be able to recall a specific event, but usually it's a twisting type injury at the time. Say they're playing basketball or playing football and sort of pivoted or moved around. And since then, they've had like focal pain, and they're able to point with one finger, like it's right on the medial side. And usually in their history, they'll also complain of like they complain of a clicking or a catching type sensation. And that's whenever the meniscus is torn, it just catches between the bones and sort of gives them that they're feeling. Again, on the medial side, there's your medial collateral ligament, and that can be from an impact there. And usually you'll, on a valgus stress test, you know, whenever you move it, just stress it, they'll just complain a lot of discomfort there over that region. Again, it's very similar on the lateral side. It can be a lateral meniscal tear, or the lateral collateral ligament can be, you know, they can have a partial tear or like a more complex tear there. So going back to the anatomy again, like we went from the medial to the lateral, and now we're just going anterior to posterior. And like over the anterior aspect, you can see like you have, again, there's your quads tendon that's just above above your patella. There's the patella itself, and then there's a patella tendon below that. And over the patella, you can see over in the dark gray areas, there's these structures called bursa, and they can become inflamed. And then in the more posterior are, and in the anterior aspect as well, you also have your anterior cruciate ligament. And then as we go further back, you get into the posterior structures. So in the anterior region, you're looking at the anterior drawer test, where you flex your knee up to around, like if they're able to do it, you know, around like 90 or 70 degrees, and you're able to draw the tibia forward. Now they don't usually find that too uncomfortable. And then there's a patella fracture, or there's the other, like there's fat pad impingement. Now, whenever somebody has a cruciate ligament injury, sometimes it might be very difficult to assess because they are sore and they are swollen, but just do your best. In the posterior aspect, you can have a PCL injury, which is a wee bit more uncommon. There's the posterior horn of your lateral meniscus, and then many people they may have a ruptured Baker's cyst as well. So with every algorithm, not everything fits it nice and neatly into the different boxes. So as I mentioned earlier on, you have the articular cartilage that covers, it's like a 2 to 3 mil sort of laminate that goes over the end of the condyles and on top of the tibial plateau. And sometimes you can injure those there specifically, and the fragment will break off, and it causes like it floats around the knee. And this again can cause like a catching type sensation. And it's the way I use, or what I would say to the patients, is like a pebble, you know, in your shoe. So it does cause a lot of discomfort. Again, it can just be a bad bone bruise, you know, like a good hit to the knee. And then more commonly in the more elderly, like they'd be on an anticoagulant like warfarin or the newer NOACs, and this can cause a hemoarthrosis in the knee. And this is where, like, yes, it can be aspirated to improve their comfort, improve their range of movement. But you have to remember the cause of this here, and it's whether, like, check their warfarin levels to see if their INR is, you know, where their INR level is, and whether it is appropriate if they are still in that NOAC, and if it is necessary. And then the more complex ones is where it's a multi-ligamus injury to the knee, and usually that'd be a high impact injury. So then we move on. That was the traumatic side. So now we're going to look at the other side of the algorithm. It's the non-traumatic injuries to the knee. So again, we'd split this up into very much, it's time dependent. And so whether you ask the patient when this occurred, was it acute? Has this only been going on for a few hours or days? And then the other ones where it's been a gradual onset, one where it's over the last weeks or months. So if it's quick onset, the things that we are really worried about, like in orthopedics, would be like if they're feverish, then you're thinking along the lines of a septic knee. And these people, they would keep their knee very, very rigid, and they're very reluctant for you to touch it. and they're you know, they won't move it. It's sort of like in a sort of semi-flex position, and they don't want you to move it at all, and you sort of can tell straight away that there is something very seriously wrong. So this should be at the top of your sort of your thought process. Again, you can have a pre-patellar bursitis, and this can be quite aggressive, and sometimes they do need to come into hospital for a course of initially IV antibiotics just to get on top of it and then to settle it down. And then there's your other more rheumatological things like gout or reactive arthritis. If they have no fever and they're complaining of anterior knee pain, especially with prolonged standing, with squatting and stairs, then you're thinking along the lines of it's an issue in the patellofemoral joint, and whether they have like chondromalacia patella or some arthritis in this region. So you wouldn't be as concerned. You wouldn't need to act as quickly, but you would be aware of it, and you may have again ordered the most appropriate investigations to look at this here. So if it is more gradual onset, we'd split into, is it just affecting one joint or is it multiple joints? If it's one joint, do you know what I mean? It's just like the right knee or the left knee. Like you'd be thinking along an osteoarthritis, and there you can see in the picture, you should have this lovely white coating, as I said before, over the ends of the bone. But whenever that's gone, they're just you can see there's just exposed bone there, and they're just walking on these regions, and it's giving them, you know, a lot of discomfort. If it's more than one joint, and say they're complaining of pain in their hands and all, again, it can be osteoarthritis, but you would be thinking along the more like the autoimmune disorders such as rheumatoid or psoriatic arthritis. But it's very important to keep in the gradual onset ones is like, so you're going to order certain investigations, and you're going to make certain interventions with these. It might be pain relief or things like this here, or physiotherapy. But if their symptoms aren't settling, it's really important you go like, okay, I've tried these things and it isn't improving. So this is where you have to keep in mind these red flag symptoms. So this is when it really doesn't fit into the, it's just, you know, there's something wrong. Usually they're young. They might, in your history, you'd ask about, are they having any night sweats or night pain? And this is when, say there is something a wee bit more sinister going on. It's where like the tumor is expanding. And also in these ones, they would be complaining of, they may have fever. So here in the X-ray below, you can see that there's the bony lesion, you know, in their distal femur. And you can see it's being quite aggressive, and it's sort of thinning out the cortex. So you would be very concerned about this here. But again, that fits in like that to be young in age, they might have like their symptoms aren't improving. And so then you'd be thinking along these lines. And then the other side of it is where they have like an avascular necrosis or a stress fracture. Say they've been out, they've started, you know, like the couch to 5K or things like that there, and then they have sustained a stress fracture. But a lot of these things you may arrange an X-ray or an MRI, and it will show. But it's just, again, like if things aren't, you know, if you are making certain treatment or making certain interventions and they're not working out, to sort of keep these in the back of your mind. So I'm just going to run through a few cases, just a few of the examples, and just how they slot into this algorithm. And they're just the common ones that I would see at the clinic. And so here's a 46-year-old gentleman playing five-a-side football 3 weeks ago, tackled, felt a pop in his right knee. His knee has immediately swollen up, and he had difficulty weight bearing initially, but then that's probably improved. And he feels like it's given way. So first of all, from this here, he felt a pop in his knee. They usually do describe feeling a pop like patients, and usually that you're thinking along, when they use that type of terminology, like it's usually a cruciate ligament. And then because it's torn, like it's gonna bleed inside the knee, and that's gonna cause the swelling. And then because of as this is one of the, you know, stabilizers of the knee, when they run in a straight line and fine, but when they go to twist or turn, do you know what I mean? They feel like it's gonna give away, and that can even be in walking. So again, you're going to use your clinical exam to have a look at them. So first of all, there's an effusion from all the swelling. There's some tenderness along the medial joint line. The range is reduced, most likely due to the swelling, from 10 to 110 degrees. They're positive anterior drawer test, and the collateral ligaments are intact. So we'll put it all together. So first of all, it's a traumatic injury. It's quite, like it happened within the last 3 weeks. He is able to weight bear now, and he has an anterior draw test. And from that there, you'd be thinking along, like your differential is going to be, okay, is this a cruciate ligament injury? Notice in the clinical examination as well, they had joint line like some medial joint line tenderness. And so that would sort of bring into question whether you had a, like a meniscal tear. And there, we've done the investigation. Like the most appropriate one for this here would be an MRI of the knee. And again, he had a cruciate ligament, an anterior cruciate ligament tear, and he also had a meniscal injury too. So you've got to the bottom of that there, and then you can refer it on to the most appropriate person. So case 2 is a 66-year-old lady with a 3-month history of left knee pain, which is very specific that it's over the inside of her knee, over the medial aspect. She has no catching or no catching sensation. She does have some pain at night and is able to walk for more than 20 minutes. And she finds now that it is affecting her while playing golf. On the clinical examination, she's tender over the medial joint line. She has a good range of movement and her ligaments are intact. So to summarize, first of all, she's a 66-year-old lady and she's gradual onset. It's affecting one joint, the knee. She has no mechanical symptoms. So what's investigation? You can get an X-ray of her knee or an MRI, because you're thinking along the lines here of that she has some degenerative changes in her knee, and it's just to confirm that. So here she had her X-ray done, and the left knee, you can see that there's on the medial compartment, there's loss of the joint space. There's some early osteophytes as well. So she's like it's quite diagnostic, and a lot of the information, especially with regard to arthritis, osteoarthritis, is from a plain X-ray. You don't need to order an MRI. And then she's underwent surgery for that. Like she probably initially would have had an injection, and then she's had surgery, and here she's had a medial unicondylar knee replacement. Patients do very well from these here because, like as I say, you're keeping 2/3 of your knee sort of your own, like your recovery is a wee bit quicker, and yeah, and they do very, very well from these. The next case is a 19-year-old Irish dancer who has anterior knee pain for the last 4 weeks. There's no clicking or catching type sensations, no night pain or sweats. So we were looking along the red flag symptoms, but they're not being flagged up. So it's mainly activity related, and it's mainly on deep flexion or squats. So again, you'd be looking, it's in the anterior aspect of knee. So it's mainly looking at the patellofemoral compartment there and seeing what's the issue. So whenever this lady did a single leg squat, she was positive, and 80% of anterior knee pain will have this here. It's quite good test. And again, she was tender along the patellar edges. Apprehension test and the grind test, I don't find that useful either. So it's usually, and again, a lot of this here you garner from the information you garner from your clinical history. Like, do they have difficulty with stairs and think going upstairs, or more specifically going downstairs? Or in this case, she's a young girl. Whenever she goes into a lunge or like a deep squat position, she finds that she's very uncomfortable. So in summary, 19-year-old girl, there's no trauma involved, anterior knee pain, as I said before, especially on squatting. So then you're looking, it's in the patellofemoral joint. And what are we going to do? Like, is it a tendinopathy, chondrulation patella, or an osteochondral defect? So the investigations for this here I'd request an MRI. And here she's had one. And this young girl had chondromalacia patella. And what it is that the articular surface, or this covering on the back of the patella, it's just not as nice and smooth as what it should be. And sometimes it just there's a few fissures, or it becomes a wee bit frayed, and that can cause them a bit of discomfort. And some of these do very well from just a very specific or tailor-made physiotherapy regime, and will have a very good outcome from this here. But they may have to make a few modifications to the way they train or the way they do different things, you know what I mean? Or they realize if they're going to do like deep lunge and squats, this is going to aggravate their injury, so they might need a few anti-inflammatories after that there. Yeah. And then the final case is case 4. So this is a 19-year-old man. It's very non-specific. It's just generalized knee pain over the last 6 weeks. No history of trauma, no mechanical symptoms. He does have night pain. He doesn't complain of any weight loss, but he does have difficulty weight bearing. So an examination, he has an effusion. He is tender over the medial aspect of his knee on palpation. His range of movement is from 0 to 90 degrees. So it is reduced, you know, like usually it's 0 to 140 degrees, isn't it? And then his ligaments are otherwise intact. So in summary, no history of trauma. It is affecting one joint, his knee. The red flag is the night sweats. Whenever I hear this here, they start complaining this here, like, you know, like I do perk up and like, yeah, I'm very concerned and I'm ordering the investigation. I'm going down to speak to the radiologist to make sure like I get this, you know, this MRI very quickly within the next few days, do you know what I mean, to see what's going on. So this patient has difficulty weight bearing. It's very unusual for a 19-year-old to be like that there at that stage. And then he also has a reduced range of movement. So again, there's a lot of things in this history where the red flags are coming up and you want to rule out, you know, like a sinister cause and you'd request an urgent MRI. And in this case, it was, they had their MRI and it was a benign janine cell tumor. Now we had classified these are benign, but they can be very aggressive. And just recently, on another note, there was one of your colleagues, a GP. There was a 34-year-old lady who was referred into myself, and she'd been out running, and then over the last like 2 months, she'd been complaining of pain, on her left knee, and it just hadn't improved. And fair enough, the red flag, like she did have a few red flag symptoms, and she wasn't improving. And your colleague did arrange for an urgent MRI, you know, for her, and it turned out to be like an osteosarcoma. So this was just one in the last few weeks, and from what I gather, like we did the full investigations, and she has undergone her surgery recently. So these things do come up, you know, like they might be infrequent, but it's just to keep your, you know, keep these in mind, not be very blasé about them. And just as I emphasized before, it's all in the history, like the patients, like it is there, and you're just using your examination to sort of confirm the findings, and just you want to use the most appropriate resources. And so like, yes, it is like it's an X-ray or an MRI. And if you are concerned about anybody, like, you know what I mean, you know, like we're all more than happy to take a call, you know, to sort of like to see these patients, get them into the clinic, you know, urgently, and sort of get them sorted out. So if you have any questions, that'd be great.
Neil, thanks very much for joining us tonight. Okay, first question from Pauline Kane. With knee pain, what would night sweats be indicative of?
Well, night sweats, as I talked in my talk, there was a few red flag symptoms, and that's one of them. Especially, like, you have to put it in the context of the patient in front of you. Like if it's a young patient, do you know what I mean? And they're having night sweats, weight loss, you know, fevers and things like that there. These are all like you'd have to be very concerned about, and they're where you'd be making more urgent investigations to see what the cause of these is, you know. But it's one of those things, like once you hear night sweats or you ask that question, they go, oh yeah, I do have that, then you should be thinking, you should be more concerned about these things. Like night sweats can affect like in lots of different ways, from hematological disorders to, you know, like a tumor, or, you know, they complain of night pain, or like in women, you know, like in later life, like they can have menopause. So as I said, like it can be, you have to put it in the context that you get it in. But yeah, it's one of those ones, once somebody says it, like the sort of like the red light should start going off, and you should be concerned and sort of making a beeline to, you know, investigate this more urgently and put it to bed.
Okay, thank you. Another question here. do you still use the Apley's compression and McMurray's test as a quick screen for meniscal tears of the knee prior to MRI imaging?
I still do use McMurray's test, but as I said, I think a lot of in your questioning of the patient about how they did it, like in a younger patient, they'll say, listen, I was playing football and I twisted my knee, or I was playing basketball and I had a twisting type injury and they complain of pain and they say it's over the inside of my knee. So immediately you're thinking, do you know, is this like a meniscal tear? And then you just use like I do McMurray's test. I do it anyway. I was just always taught to do it that way. But then you're always going to get an MRI to confirm it, you know, that way. So, but usually in your history, you sort of have a fair idea of what the issue is. And then like if they complain of a pop, as I said, it's more likely to be a cruciate ligament. And if it immediately swells up afterwards, you're thinking, look, there's been a bleed in the knee following this here, so it can either be the ACL or the meniscal tear. And for both those, you're going to get like if they came to see me, you would get an MRI. Like, but a lot of them are referred in with an MRI by the GPs anyway, so it's great. Do you know what I mean?
Okay, Neil, thanks very much for joining us tonight.
No problem.
And thanks everyone for joining us. We will be having another event in April and one in May, and they will be up on the website, and we'll also send out emails. Don't forget to see if you want your CPD cert, just press the tab, and please register for this event to get the CPD cert as well. And we'll see you next time. Thank you very much.